As far as his healthcare experience, it's extensive. He was president of the Regional Medical Center from 1986 to 1990, executive vice president at Methodist Health Systems from 1990 to 2001, and as I think most of you know, president and CEO of Methodist LeBonheur healthcare system from 2001 until now. It is a real joy to have Gary, and as soon as we have the prayer, I'm going to invite Gary to come forward. Thank you, Gary, for being here. Let us pray. Almighty God, we give you bountiful thanks for the blessings of life. You are so gracious and good to us. We also thank you, O God, that in those moments of trial, difficulty, you come to help us. Your healing presence that touches us physically, spiritually, and emotionally is a gift to us. We lift Leland and Betty and Lisa and all the family before you, O God, in a special way. Touch them with that grace. Work through the medical personnel, the medical technology, all of the avenues of medical care there in Rapid City. Come as divine physician and touch Leland in a way that only you can. Betty understands, oh God, what we understand. And you promise us your divine grace and presence, your healing touch. But you do not promise us the results we always want. For this family, oh God, as we do, look to you, lean upon you, and trust you. Thank you for this time of fellowship, for our food, and for the stimulation to be persons committed to healthcare ministry in this community and in our world. And we do pray all of this in Jesus' name. Amen.
Thank you, Richard, and good evening to all of you. It's great to be among fellow United Methodists and among old friends. Ed Robertson's here. He's the former chairman of the board of Methodist LeBonheur Healthcare. Served on the board for about 12 years. I see Jerry and Bob Howardson back there. Bob really got the whole division of faith and health started at Methodist. And Bob, we still are building on that foundation that you laid. I thought I saw Rick Kirchhoff, who's now a member of my team, working on a lot of different initiatives that we've got going on in the health system. So it's great to be here. The question that Richard and I came up with that was worth asking, and that I'm going to attempt to answer, is where are medical costs headed and what can be done about it? What I thought I'd do is, the whole issue of healthcare today is obviously a complex one, and there's no way you can boil it down to just a few topics. But what I thought I'd try to do is hit on a few topics. First of all, kind of describing why costs are escalating the way they are, and then talk about some of the solutions and really focus on the local solutions that we're working on as a health system and as really a community partner with other health systems, Baptist and St. Francis, as well as other organizations throughout the community. The Methodist LeBonheur Healthcare System is a ministry of the United Methodist Church. We take that ministry very seriously. We care for more poor people than any health system in the state of Tennessee, as measured by TennCare patients, Medicaid patients, and patients who have no ability to pay. So I hope you all take a lot of pride in the fact that we were founded 95 years ago by a Mississippi planter, a United Methodist, and that we've maintained the heritage and the commitment to serve all parts of our community and especially serve the poor. Healthcare, it truly is a paradox in this country. I mean, we are the most powerful, the richest, probably the most innovative nation in the world. And yet, even with all the wealth and the smart thinking that we have health status indicators that lag almost any developed country in the world. So it really is fundamentally a question of what are we doing wrong, what's the rest of the world doing right in so many ways, and what can we learn from the rest of the world, and what do we have to do differently. I mean, without a doubt, our healthcare system has the best technology, some of the best trained physicians and clinicians. People with the wealth from other parts of the world come to us for the high-end treatments without question. But we also have, again, a cost overrun that's tremendous. And for a lot of our population, they are in a health status that's just not acceptable. So what can we do about this? First of all, just some statistics that prove through data what I just stated. Right now in the United States, we spend about $7,600 per capita on everybody's health. It's about 18% of the gross domestic product, which is at least double any other developed country in the world in terms of total expenditure. And our life expectancy is in the mid-70s, and other countries like Japan, who spend about 50% or less of what we do, have life expectancy well into the 80s. So it again begs the question, you know, what is going on and what can we do about it? Just to pile on with some other statistics, when you look at some of our outcomes and health status indicators like heart disease, overall as a nation, we have about double the heart disease of many other developed countries that again have those mortality rates that are much lower than ours. And Tennessee especially. I mean, we've got a real problem in Tennessee, especially in southwest Tennessee, where we have one of the highest heart disease mortality rates in the United States. Stroke, same thing. We've got one of the highest stroke mortality rates in the U.S. in Tennessee. The highest rates of stroke mortality occur right here in West Tennessee. And obesity. I mean, everybody's familiar with this problem. We, as a nation, we've got a real problem. The trends continue to go in the wrong direction. We, in Tennessee, for adult obesity, rank next to the highest. Thank God for Mississippi. They always help us out, and they come in number one. But the top 10 out of 11 states with the highest obesity rates are all in the southwestern part of the country. So particularly for our region, I mean, we've got some serious health status indicators that are going directionally absolutely south, and we've got to figure that out. Another item that is contributing to the high cost is not just our health status and our lifestyles, but also the fact that we have so many uninsured in this country. We right now have about 52 million uninsured. Those numbers have gone up every year for the last 20 years, unfortunately. So that's 18% of Americans. That's 1 in 5 of us are uninsured. I have two stories about that just demonstrate for you how that contributes to this overall cost of care being so high in our country. It was about 6 weeks ago, I got a call about a patient who was a 34-year-old man. He had, as a father of 3, he was uninsured. He needed a bone marrow transplant. The reason he needed a bone marrow transplant was because about 18 months ago, he was diagnosed with cancer. The dentist found it. You happen to be going to a dentist. He had oral cancer. Because he had no money and he had a lot of pride, he did not want to go and get any free care anywhere. So he kind of let the situation go until it really got out of hand. The cancer spread. He needed a bone marrow transplant. We went ahead and did that. Unfortunately, he waited too late. So the bone marrow transplant did not take. We could not save his life. And the unfortunate thing is the prognosis for him 18 months ago when the cancer was first diagnosed was very positive. This man could have lived a healthy life. He could have lived out his 76-plus years. But because he didn't have access to health care, or felt like he did not get the care he needed. And in fact waited so long that the care that was provided was about $200,000 plus in medical care that was given to him for free. And we were happy to do that. The outcome obviously wasn't what we wanted, but it just demonstrates to you that if you let things go on too long and people don't have access to the appropriate care, costs do rise. And when they finally do reach the emergency room or some other portable care, it's generally too late, and it's generally very, very costly. So covering people is very important. One other story is a call last week from the Tennessee Justice Center in Nashville. They had a 62-year-old former nurse who had no health insurance, and one of the prestigious transplant programs in Nashville was not giving her access to a transplant because of her uninsured status. And their fear, and this is legitimate, that she would not have the money to pay for the drugs that are needed post-transplant. You have some very expensive drugs. Family came up with the money. This organization still said, no, we're just not going to do it. So we've taken her. She is in our hospital. She's #1 on the transplant list, and right now is getting the transplant. Interestingly enough, too, the Tennessee Justice Center worked with us, and we got her on TennCare. So she's going to, I think, have a great outcome, and she'll live probably another 10 or 15 years. But again, it's that access to care, it's that lack of coverage for these 52 million people that it's a cost issue, but it's also a moral issue for us. And we need, as a nation, to really be more aggressive in trying to address it. Now, the Affordable Care Act, that was one of the fundamental reasons it was passed, was for coverage, and we can talk a lot about that. Portions of that act have been implemented. It is beginning to impact the uninsured in a very positive way, and when the health exchanges start, we are going to see, I think, a real movement toward coverage. And I hope that Tennessee, I hope we can get Medicaid expansion passed, or the Tennessee plan passed. And Governor Bredesen seems very intent on doing this. So my hope is that we can begin to really aggressively address that part of the overall cost problem. The other thing that contributes to our costs as a country that no other nation has is just the high administrative costs. We've got a very fragmented system of care. We have hundreds of private insurance plans. Most of them have overheads that run anywhere from 5 to 20%. That's very inefficient. And it's difficult, again, to get your hands around what some of the solutions for that are, but clearly we've got to address all of the administrative expenses we've got related to health care. Interestingly enough, Medicare is the most efficient when it comes to overhead expenses. Medicare runs at 3%. Other nations who have government plans run at about 5%. So you can say what you want about Medicare. It provides pretty good coverage. We have difficulty dealing with it. Doctors do too at times. But it is an efficient and pretty well-run organization. And you would think that if anybody could get their act together and pull all the pieces together and just have one plan, it'd be the federal government. But even the federal government's fragmented. We've got Medicare, we've got Medicaid, we've got the VA system, we've got the military system, we've got a separate system for Congress. I mean, we can't even get under one umbrella everybody to try to work together to have one comprehensive plan. And it's a crazy quilt, and all of this has been evolving over years of different laws being passed and different products being put in the free market, and it's going to take a while to unwind it. But let me just suffice it to say, on the cost side and on the assessment of the overall health system and how we stack up, that if you measure it and benchmark it against other systems, we as a national medical system, when you look at something like avoidable mortality, now that's, you've got a disease, how likely is it that what we do is going to cure that disease, and you look at it for the entire population, we come in dead last among developed countries and wealthy nations. So clearly we've got some systemic problems we've got to solve. And I think the solutions are really going to be largely driven locally. So what are some of those solutions we've got to work on? Well, I've already talked about coverage. That's really important. That's not a local issue. That's national and state. And January 1st, we'll see what happens with the health exchanges. They are going to be implemented. We're signed up with them, as are many of our physicians. Again, it remains to be seen what the overall ramifications of that are going to be. Moving to accountable care organizations, you've all probably heard about those. We're working on those here locally, and what happens with those is it changes the whole mentality and mindset of providers from how much more can we do for you to generate more revenue, and unfortunately that's how the fee-for-service payment system works, to getting a payment for a bundle of care, like you come in for a total hip, then we get one price, and our objective then is to work with our physicians and treat you very efficiently with the best outcomes that we can possibly provide, and do it for one price. So it begins to align incentives and begins to drive efficiency and also higher quality, which also leads to higher efficiency. Corporations are beginning to do this pretty aggressively, change the payment system. Walmart right now is touting a system they've put into place where if you're a Walmart employee or a family member and you need heart surgery or you need a spinal fusion, there are only 6 places in the country you can go. The Cleveland Clinic, Virginia Mason Hospital out in Seattle, the Mayo Clinic. They've selected which ones you can go to, and they've selected them because the outcomes are the best and the cost is the lowest. So all of us as providers are saying, whoa, this is a new world. Corporations are going to fly people all over the country to get their health care for very specialized care. This is definitely going to be the future for us, so we better pay a lot of attention to it. Interestingly enough, the CEO at Virginia Mason is a friend of mine. Again, that's in Seattle. And he said 1/3 of the referrals they're getting from other parts of the country are patients who do not need heart surgery, which again speaks to this variation we have in healthcare and diagnosis and treatment. And the more we can get to best practices in how we do things and more consistency in how we do things. And I'm speaking as a hospital guy and just telling you, we, even among our 7 hospitals in Memphis, have a hard time standardizing everything we do. But that's the 3rd priority I'd mention to you, is reduction of variability, more standardization of processes. That'll drive higher quality and more efficiency. Virginia Mason CEO, and this is one of the most efficient hospitals in the country right now by multiple indicators. In fact, they send every one of their board members and executives to Japan to go through the Toyota Quality Improvement Program. That's how serious they are about driving process improvement. He estimates there's still 30% waste in his hospital. So that gives you an idea of the magnitude of the opportunity here that we're dealing with as an industry. And it's one, again, that's going to have to be driven pretty much hospital by hospital, physician group by physician group, working in partnership with the physicians. Another thing we've got to do is engage the patient and the family more in the care. I've had an experience over the past 2 years with my mother and father, and even though I'm a hospital administrator, I'm in hospitals all the time, for the first time, I've never been an inpatient, which, knock on wood, is a good thing, but for the first time, when my mother got sick about 1.5 years ago, I had to go to Florida and spend about a week with her sitting in the hospital room. Well, that really is an experience that I, again, have never had. And a couple of things struck me. One is she was misdiagnosed, and there were many opportunities for medication errors and other things while we were in the hospital. And I guess, obviously I'm pretty attuned to all of that, being being a hospital guy. But then secondly was just the number of providers that came in the room and didn't acknowledge the family, barely acknowledged the patient, and didn't really inquire from any of us as family members about history, current status, when we as family members and you as family members know more probably about what's going on with your loved one lying in the bed than anybody. So one of our major goals over the past 2 years has been to change that whole dynamic, and it's called Patient and Family Centered Care. We are opening up our ICUs so you can stay there 24 hours a day if you want. We are trying to make communication totally very much directed and very transparent. If you have a question, ask it. If we're not engaging you in a conversation about your family member, then something's wrong. Because that's the kind of culture that's going to lead, again, to better care, better outcomes, and higher efficiency. Another component of that as a health system we're being more and more deliberate about is the spiritual side of healing, and really engaging the family and the patient more in where they are from a spiritual perspective. I mean, mindset, spiritual outlook has so much to do with overall quality of life, so we really are going to be doing a lot more on that front. Another item that you've all heard about and are probably experiencing right now is more personal financial responsibility for your care. So a lot of corporations are moving to high deductible plans or high copays or health savings accounts, and they are putting you in the position of being the purchaser for the first $3,000 or $5,000 of care, which makes a lot of sense in terms of a market-driven solution to what we are dealing with. We're going to be more price sensitive in that you're going to be looking for the best deal. If you have to have a CT and you're going to have to pay for the whole thing out of your health savings account, or an MRI or any other diagnostic procedure, you're going to want to know, well, what is this going to cost? How much is going to come out of my health savings account? And that is having a big impact, and a positive one, on how we're beginning to think about pricing and also how we're overall marketing our services. So that will definitely be driving some costs down. Probably the biggest thing that we've got to work on, and that we really, as health systems, spend very little money or time on, is wellness, health promotion, disease prevention. So we're trying to get into this in a much larger way and begin to set aside more resources for it. One of the strategies that we have is called the Congregational Health Network, and it is a strategy that now has engaged 500 congregations throughout the community, and we are working with them on education plans for patients. If you have diabetes, we want to be sure you're well educated about how to treat your diabetes. If you have hypertension, we want to be sure you understand what you can do to improve your hypertension. If you've just been discharged from the hospital, then what can we do to ensure that you take your medications and that you're getting the attention you need so you don't have to come back for a readmission? Because now the federal government is imposing some penalties, which is also going to have an impact on cost, a positive impact on hospitals who have readmission rates that are too high. So a lot of attention on that, some incentive for us to get out and try to be more aggressive there. And this Congregational Health Network is one strategy to do that. But there are a lot of other strategies. I mean, we've got to get people a lot more engaged in their health. How many of you have ever seen this? It's a Jawbone Up band. You may have heard of the Nike Fuel. It's very similar. So you wear this and it counts your steps. It tells you how good you sleep. You can crank in what you've eaten. It tells you how you're doing from a calorie standpoint. And it just begins to be a real subconscious reminder, or even conscious reminder. You got to get your exercise. You got to eat healthily. You really do have to get good night's sleep, and it begins to really impact how you think about, what you're doing every day and how that contributes to your overall health status. strategies like this, strategies like iPhone apps, 90% of the people in Memphis have a cell phone or an iPhone. So this device is not restricted any longer to the rich or the middle income. I mean, even the poor have some type of device. It may not be the same smart device I have, but it's some kind of device that we, if we get smart about all this, can use to really try to impact in a very positive way their health and begin to bring down these costs and improve overall health status. Something else we're doing is working with other providers in a cooperative called Healthy Shelby. So Baptist, St. Francis, the mayor, Luttrell, a lot of providers are coming together, and we're focused on 3 areas. One is chronic disease management, and specifically hypertension. How can we address high blood pressure in the African American population is the first area we're looking at. Secondly is infant mortality. Big problem for us. We're beginning to see those numbers go down, but we have different strategies now that we collectively are working on to try to impact them even more. And then lastly is end-of-life care. For the Medicare patient, about 30% of costs are incurred in the last 2 years of life, and many of those costs are really inappropriate. I mean, they're just futile care that we're providing that is not necessary care. So how can we be more deliberate about getting everyone to think about their advanced care directives, their instructions for their end of life? How do you want to be treated? Do you want to be on a ventilator when you die? Or do you want to be in a residential hospice, or do you want to be at home? So we're trying to have those conversations. They're tough ones to have. We've distributed a document called The 5 Wishes to all 11,000 of our employees and asked them to go home and have these conversations with their families. And we hope that's the start of a lot of conversations that'll be had and a lot of advanced directives that'll be signed. Let me just end by, and then open it up for questions, by saying that one of our visions as a health system is to be one of the best health systems in the country. We have a lot of ways of measuring how well we're doing against that goal, but probably the most visible is whether or not you're listed in the U.S. News and World Report Best Hospitals. I'm very proud to say that LeBonheur, for the 3rd year in a row, has 5 specialty areas listed. LeBonheur is now 23rd in the nation out of 270 pediatric hospitals in the country. So on the pediatric side, our children in our community, regardless of ability to pay, from all walks of life, in every quadrant of our city, getting world-class care, getting the best care that's out there in our nation. I think that should be a point of pride for all of us. And Mary Armour and her team, she's the CEO, have done just a fabulous job of making that happen. We've recruited 26 new physicians to LeBonheur in the last 2 years. They've come from places like Boston Children's, Philadelphia Children's, Houston, Dallas, and we've gotten some of the best people. Having a new $350 million hospital helps with that a lot, but also really having a very competent team running the hospital and talented physicians with the University of Tennessee already in place was a big contributor. So we're trying to do the same thing on the adult side. That journey is going to take a little longer. We're recognized as the best regionally, but we really want to be recognized as the best nationally. Again, to make all of you United Methodists proud of what we do in our community. So, I hope you all have some questions and we can make this interactive, and let me just stop right there. Yes, sir?
How does Christ Community and Church Health Center and so forth, how does that all fit into this?
Yeah, that's a great question. Christ Community and the Church Health Center are strategic partners, very important partners to us. We have supported Church Health Center since its inception, and their work is fantastic. In fact, what Scott's done with his wellness center is really a model for the rest of us to follow, and we are trying to learn from that. Christ Community, we help them capitalize a couple of new locations, and we'll continue to do that because they really are a wonderful primary care organization, and they provide care in parts of the city where nobody else is there. So right now we're working with them in 38109 to open up expanded capability down there, because that particular zip code has some of the worst health statistics in our community, and so many of our uninsured emergency room visits at South and University Hospital come from that area, and they don't need to be in an emergency room. They just need to be treated by a primary care or a nurse practitioner or clinician. So really important. Yes, sir.
What do you see as the role of the parish nurse / faith community nursing, particularly in local churches?
Yeah, I see it expanding. And, you know, Scott and the Church Health Center right now are the epicenter for parish nursing. And we're very supportive of that. We're going to try to move that whole strategy into our congregational health network strategy. You know, all of us really need some type of care manager when you think about it, and a parish nurse would be an ideal way to provide that care manager. And we all need primary care clinicians, whether it's a nurse practitioner or a physician assistant. If you're up in age like me, you need an internal medicine doctor. It's interesting, though, in our employee population, only 60% of our employees have a primary care physician, which tells you, even in the employed population, we aren't getting people into an appropriate screening and just overall, you know, health checkup that we should. But that's a great question, and we're totally supportive of it. I think that is a big part of the future. Yes.
How are we addressing?
Hey, how are you?
I'm well. You?
Good.
How are we addressing really starting at the beginning, which is getting the education in the school system and the activity that was taken away, as well as the balanced meals and information that they can actually take home and start helping change food choices in the home, because if not, they're not going to stop.
Yeah, good question. So food in the home is probably one of the biggest challenges we'd have in particularly the poor population. We have had a lot of dialogue with Billy Orville and the school system about diet. Now, you know, they have got now their head of nutrition. This guy knows what he's doing, and he's doing a great job. So the public school system may be ahead of the private schools in many ways. LeBonheur is working to become the nursing practice for the school system. We aren't going to get that done for another year probably, but that's a real important piece of the education. But you're right on target. We need to get to kids early on, and exercise has got to be a part of their daily regimen, and for so many right now it's not. But that's a very important initiative. Yes, sir.
Do you think you're going to be rational with care with the efficiency and cost of working?
I do not. I think, as I stated, the opportunity to continue to improve quality and processes and thus improve efficiency are so great that we should never have to ration care. And unfortunately, you know, in the two cases I described of the uninsured, I mean, basically that's care rationing. I mean, those people couldn't get access to care. It's not a deliberate effort at rationing, but it's an unintended consequence of not having appropriate health care coverage. But I just don't see that happening. We've got a long way to go before we get to that point. It would take a lot of different economic dynamics.
What about these death bills? What about it? So what being appointed bureaucrats in Washington are going to make the decision as to whether we get health care or not.
Yeah. Well, from my reading of what took place there is the Washington effort was really one that was trying to promote some guidelines for appropriate care at the end of life. Frankly, I think we need to have that discussion a lot more aggressively. That too often, as I said, 30% of the Medicare expenditures in the last 2 years of life and too often it is futile effort. It is just care that's imposed on somebody that does not provide comfort. In fact, it provides stress and discomfort in the final, weeks or days of life. I mentioned my mother's situation. That's exactly what was happening to her until an internal medicine doctor stepped in, had a very good conversation with the family, and we put her in residential hospice where she was kept comfortable. We surrounded her for the last 2 weeks. We talked about a lot of memories. We had a lot of enjoyable times together, and that was so much better than being in a hospital room or being in an ICU. I mean, there's just no comparison. So that's the kind of conversations we have to have more and more as families and as health professionals. Death panels, I just cannot envision that ever happening. I mean, I really can't. I think the ethics in the industry are so high that we just won't allow that to occur. Yes, sir.
Backing down from that a bit, somebody told me recently that their, I think it was knee replacement, had to go before some panel. Is this a lower level version of it?
Well, yeah, I mean, there is pre-certification that's done by some insurance plans, and there is no doubt that there's scrutiny given to procedures that are recommended by physicians. My experience is that generally, if you need the procedure, you're going to get the procedure. I can't think of any case that's come to my attention where care was denied for pure economic reasons. Now, I'm not saying that doesn't occur. It could, but it hasn't in my experience. Jared?
Speaking of hospice and end of life, is anything special going on for both education and individuals to take responsibility for end of life and directing it in the way that we think it should go?
Well, that was the most extensive education is this 5 wishes document. Very simple document, great questions about how you want the end of your life, or I want the end of my life to be, and you sign it, your family witnesses it, you keep it, and it's a legal advance directive that you can take with you into a hospital or your family can bring in. That right there would make a huge difference if we could get everybody to do that. Jerry, it really would. Yes.
I have a copy of that 5 wishes from the hospital.
Yes.
And it's a guideline for what you need to talk to your family about.
Right.
And it's worded so that you could ask anyone in your family to talk to you about this and see your wishes and how you want things to happen. And I really it's to everyone.
Well, I tell you what, I'll get a couple 100 copies out to Richard, if that's all right, and y'all can have access to it as a church, because I've used it in our family, and it's a little tough, I mean, but it's very good. Yes, sir.
We're always lined up to do that in September with you.
Perfect.
William has already.
Perfect, thank you. That's great. Yes, sir.
A different kind of question. You had talked about the high deductible and co-pays and trying to have us be more responsible about making decisions. But to do that, pricing needs to be readily available. Do you see that coming? I just had a knee replacement, and I chose the hospital based on convenience of getting my family in and out of it, and was unable to get any kind of pricing to compare, situations about which would be the best place.
We have not done a good job as an industry or as an organization of being transparent about pricing. And right now, pricing is a complex mess. And it is because, everything is driven off of a pricing schedule and then discounted significantly. And that's how the payment system has worked for years. And as a result of that, charges or price